So this is a very busy slides, but what I wanted to highlight is the hydralazine group of the drugs, which was a VELF trial, VELF-1 trial, which was conducted long before in 1986. And now hydralazine is to be considered as a reserve drugs, or those who are Africans Americans or associated with the renal failure. Hydralazine is not the first line of treatment. The angiotensin receptors inhibitors are the VELF-2, SOLT trial, SOLT-T trial, Concises, and the Atlas. These all greens are on the angiotensin 2. And if you can see, there is a big emerge of interest in 1990s with the captopril followed by lisinopril, enalapril, ramipril, and perindopril. These all has created a big impact in management of the heart failure almost 3 decades before. Mineralocorticoid steroids inhibitors also in 1999s, beta blockers, CBIS trial, and the MERIT heart failure trial in 1999 has clearly shown that one upon a time we used to say that beta blocker is contraindicated in heart failure because it reduces the contractility of the heart failure. But now it is one of the cornerstone of the therapy, and largest reduction in mortalities happen only with the beta blockers because beta blocker prevent the sudden cardiac death. And digoxin is never to be forget when there is an associated atrial fibrillation. And these are all the pillars where we are started almost last 30 years. We are using this group of the drugs, and it has make us understand that heart failure is important. But what is most important is, up till now, there was no head-to-head comparison between this group of the drugs, that whether this particular group of the drugs is superior to the another active competitor which are used for the heart failure. So the paradigm HF heart failure head-to-head comparison, if you look into the dark black border in the pink color, paradigm heart failure, where there is a head-to-head comparison with the active competitor enalapril, and which has clearly found a superiority of sacubitril valsartan as compared to the enalapril. And DAPA heart failure and EMPA heart failure has also make a lot of changes in understanding and given a guideline directed now therapy, and they are now included in all the guideline of ACC, ESC, and Canadian guideline as a first line of treatment for the heart failure patients. And then comes with all these group of the drugs, there was a big step forward, and that was a paradigm heart failure. And I will discuss little bit on paradigm heart failures trial because one need to understand what exactly these drugs has proven in this trial. So these are the patients which are a stable heart failure, NYHA 2 to 4, ejection fraction less than 40%, and they have intended to find the primary endpoint of CV mortality and need of first hospitalization for the heart failure. Now, initial 1 month or 2 months were the single blind active run-in period. So now what they've done is, very interestingly, all the patient has been given 2 weeks for an enalapril 10 milligram twice in a day. Then they have given these patients a washout period of 36 hours. And this same group of a patient has been put again on sacubitril valsartan 100 milligram followed by 200 milligram for another 1 month. So these are the super selected patients who have tolerated enalapril, who have tolerated 200 milligram twice in a day of sacubitril valsartan. So you can understand this is very important in starting a patient's in an OPD base, because majority of our patients were never able to tolerate this 200 milligram of twice in a day very upfront, and we need to go very slowly from 50 to 100 to 200, slowly increasing acceleration of the dose depending on the blood pressure. Now that onwards, patient has been double-blinded, given a 200 milligram twice in a day, sacubitril valsartan, and half of the patients were given a 10 milligram twice in a day enalapril. Total 8,400 patients were studied and randomized, almost 4,000 patients in each subgroup. They were class 2 to 4 stable outpatients. They were last 4 weeks, they were either on ACE or ARBs and the beta blocker. NT-proBNP levels were high, and they were continued on a standard of care therapy. On top of that, they have received either enalapril or sacubitril. Exclusion criteria: those who are hypersensitive, those who develop angioneuritic edema, and one need to remember, ARB group of the drugs can result in angioneuritic edema. So that is a very common side effect which is observed with the ARB. eGFR should be more than 30. Those who are less than 30 has been excluded. So if you are treating the patients with the cardiorenal syndrome, with the heart failure, if the patient's eGFR is more than 30, then and then use. Otherwise, these patients will not be benefited. When they are enrolled, the systolic blood pressure less than 100, they were excluded. So we have to use when the patient's pressure is more than 100. And if they require ACE or ARBs for some compelling indications like hypertension, then they are excluded from the treatment. Potassium level, hyperkalemia are excluded. Acute decompensated heart failure or severe pulmonary other disease like interstitial lung disease or a COPD, these patients were excluded. So we need to remember these particular things, that eGFR less than 30, don't use. Systolic blood pressure should be at least more than 100, and potassium should be normal while you are treating, and patient should be stable from NYHA class 2 to 4, ejection fraction less than 40%. And this is the largest mortality and morbidity trial in a patients with the reduced ejection fraction. Many geographical diverse area has been included. So we cannot say, one cannot say that, okay, this particular trial do not have Asian patients or Indian patients, and we can't use the extrapolate the Western data. There are good number of almost 4,000 patients from the India were enrolled in this, 800 or some 1,000 patients were enrolled in this particular trial from the India. And now let us understand what is the results versus sacubitril valsartan in a red versus enalapril in a blue. If you look at the reduction in cardiovascular death, there is an absolute reduction, relative risk reduction of 20%. Need of hospitalization of heart failure reduces by 20%. Overall mortality reduces by 16%. Heart failure death reduces by 21%. And most importantly, this group of the drugs shows first time reduction in sudden cardiac death by 20%. So this is again important, because up till now for sudden cardiac death, we were more relied on a beta blocker, but here also it has shown that sudden cardiac death is reduces by 20%. And these are the other pillar, which and how is the reduction in mortality and need for the hospitalization of the heart failure. ACE inhibitor 17%, beta blocker CBS2 trial, as I mentioned, the largest reduction in the mortality because of prevention of sudden cardiac death, 34%. So if you look at the sacubitril valsartan data, what was that? They were already on beta blocker and ACE inhibitor. So your patient is getting benefit of ACE inhibitor and beta blocker. On top of that, there is a 20% relative risk reduction in a cardiovascular mortality. So this is again a big statement. It is not like a 20%. On standard care, you add these, you get 20% relative risk reduction, better as compared to those who are not on sacubitril valsartan. Now, can this group of the drugs can change the NYHA class? So let's say patients of NYHA class 2, 3, 4 are included. In a red is class 2, which is a maximum number. So this is a pre-sacubital valsartan on the left, post-sacubital valsartan on the right. And if you look at the chart, there are 73% of the patients were on class 2. Post-sacubital valsartan, it reduces to 58%. But at the same time, NYHA class 1 from 8.6% is almost increased fourfold to 32%. NYHA class 3 has reduces to half from 18 to 9.5. So clearly this group of drugs has, we can say it is a symptoms or a class changer, and hence the quality of life improves with this group of the drugs. Coming to the various sub-analysis, whether it works in elderly or a younger, ejection fraction less than 30, more than 35, EGFR of less than 60 or more than 60, blood pressure of less than 120 and more than 120, NT-proBNP less than 1600 to more than 1600, all these subgroup of the patients has responded similarly. So as long as your EGFR is more than 30, your patient is of any age group, ejection fraction less than 35, systolic blood pressure 100, or any NT-proBNP, RNA found to be superior as compared to the enalapril. And this is my last slides, which I wanted to highlight, particularly the Asian subset. If you look at the East and the Southeast and the Southeast Asia, where the India comes, these all the Asian subsets and the sub-subsets, they found a primary composite of endpoint of hospitalization of the heart failure and cardiovascular death, individual hard endpoint of cardiovascular death or hospitalization of the heart failure, and overall death, they all found superior with sacubital valsartan as compared to the enalapril. So in nutcrux, I summarize that heart failure is a very important issue, deadly issue. It is bigger problem than a malignancy. We are getting a younger and younger patients. Our patients are more prone for hospitalization and death, and we are lacking standard of care of therapy as well as the adherence. And one need to start sacubital valsartan as early as possible following discharge or at the time of discharge or in the OPD to give a better outcome to this sick group of the patients in India. Thank you very much.